Hello, and welcome to episode 35 of the Brain Cancer Podcast. In this episode, I wanted to sit down and have a little chat about dexamethasone. I want to briefly just talk about what it is, some of the side effects, a couple clinical trials that I have found, and some information that I have found about how dexamethasone directly relates back to us as brain cancer patients. In particular, I wanted to cover an article that talks about immunotherapy and the use of dexamethasone because it is a steroid. Before we get into that, I want to say thank you so much for tuning in, taking the time to listen, and being such an amazing audience. I'm sorry this episode is a bit late. It's just been a crazy summer, and I've had a whole lot going on, but I'm doing the best that I can. One thing that I will be actually putting out another episode for will be at the end of September, when I will have hit my 6-year milestone from my first surgery. I'm really excited to be able to celebrate, I guess if you want to call it that, 6 years of being somewhat of an outlier for a glioblastoma patient. As we all know, glioblastoma is a horrible disease, and while our treatments have been slow to adopt, people are living longer, new treatments are available, and I really believe that right now we are in the middle of a brain cancer treatment revolution with more options than we have ever had. More clinical trials, more funding, more research. We all know more of that is needed, but we are making progress. So what is dexamethasone? It is a corticosteroid that prevents the release of substances into the body that cause inflammation. It's used to treat many different inflammatory conditions, such as allergic disorders and skin conditions. In our cases, it's used to control brain swelling, and it will also help to reduce headaches, although that is also a side effect. But the reduction in swelling will naturally reduce the chances of severe headaches. More specifically, dexamethasone is a glucocorticoid. Glucocorticoids are a type of corticosteroid hormone that is very effective at reducing inflammation and suppressing the immune system. Remember that part. Inflammation is the way our immune system responds to harmful substances and trauma and is part of our healing process. However, if the usual control mechanisms that turn the process of inflammation off aren't functioning properly and it continues unabated, our tissues can become damaged. Continued inflammation is associated with many chronic conditions. Are glucocorticoids safe? When given at recommended doses for short durations of time, glucocorticoids are considered safe. One-off doses, even if they are large, or short-course therapies of less than 1 week, have few harmful effects. However, more regular or extended dosing has been associated with a number of severe side effects. If glucocorticoids are given on a daily basis at a dose equivalent to prednisone 15 milligrams a day for more than 3 weeks, the adrenal glands stop producing glucocorticoids and the tissue in the adrenal cortex begins to atrophy, which is die off. This is of concern if the glucocorticoid is suddenly stopped because the adrenal tissues will not immediately begin producing glucocorticoids again. This is called acute adrenal insufficiency, and symptoms include irritability, nausea, joint pains, dizziness, and low blood pressure. To avoid this happening, steroid medication should be withdrawn slowly over several weeks or months to allow the adrenal cortex to resume its full functioning capacity again. Evening doses should be discouraged as they can cause insomnia. Instead, glucocorticoids are normally taken just once a day, or if taken twice a day, should be dosed in the morning and again at noon. Because they suppress the immune system, they increase the risk of infection. Certain viral infections, such as measles or chickenpox, may have more severe course in people taking glucocorticoids. Long-term use can cause Cushing's syndrome. Symptoms include a fatty hump between the shoulders, around face, weight gain, irregular menstrual cycles, fatigue, and depression. For dexamethasone specifically, some of the more common side effects are aggression, agitation, anxiety, blurred vision, headaches, mental depression, nervousness, numbness, acne, an increased appetite, and a swelling of the fingers, hands, feet, or lower legs, which is edema. Dex is something that I only experienced during my first surgery when I was in the hospital. And then after I was released, I was on a 4-day taper schedule. I had mentioned before that I don't remember if it was 4 milligrams, 3 milligrams, 2, 1 done, or if it was perhaps 8, 4, 2, 1 done. But either way, it was a 4-day taper to get me off of it as quickly as possible. And I couldn't wait to get off of it because all I was doing was just eating and eating and eating. And my arms, specifically for some reason, were all broken out in weird acne, and it was gross. I didn't like the way it made me feel at all. I didn't have much problem sleeping because my doses were earlier in the day. For my second surgery, I specifically asked to not have any dexamethasone and that I didn't want to have any for after I had been discharged. I hardly had any swelling after my second surgery, so there was very little need to have it anyways. I do know some people who have been on it long term, and it just permanently changes who they are, and it's not great. If anything, it should push us to try and find new ways to reduce brain inflammation that don't rely on steroids. There must be something else out there, but we'll just have to find it. I briefly wanted to talk about a couple studies that I've also pulled up and did a little reading on. And there's one here called Evidence-Based Dexamethasone Dosing in Malignant Brain Tumors. What do we really know? The purpose was to conduct a systematic review of literature reporting on the dose and dosing schedule of dexamethasone in relation to clinical outcomes in malignant brain tumor patients, with particular attention to evidence-based practice. The results: after screening 1,812 studies, 15 articles were included for qualitative review. Most studies reported a dose of 16 milligrams, mostly in a schedule of 4 milligrams 4 times a day. Due to heterogeneity of studies, it was not possible to perform quantitative meta-analysis. For brain metastases, best available evidence suggests that higher doses of DXM may give more adverse events, but may not necessarily result in better clinical condition. Some studies suggest that higher DXM doses are associated with shorter survival in the palliative setting. For glioma, DXM may lead to symptomatic improvement, yet no studies directly compared different doses. Results regarding edema reduction and survival in glioma patients are conflicting. The conclusions are that evidence on the safety and efficacy of different DXM doses in malignant brain tumor patients is scarce and conflicting. Best available evidence suggests that low DXM doses may be non-inferior to higher doses in certain circumstances, but more comparative research in this area is direly needed, especially in light of the increasing importance of immunotherapy for brain tumors. This is the important part for me. I am a huge advocate for immunotherapy, and I believe it's one of our most promising paths for treating brain cancer of all types. While I am only a sample size of 1, I had great success using an immunotherapy clinical trial. This conflict between steroids reducing your body's ability to fight off an infection and the entire idea behind immunotherapy are conflicting, which leads me to another study which I found here. This study from December 28th, 2020, titled "Steroids May Limit the Effectiveness of Immunotherapy for Brain Cancer," gives a lot more detail, and it outlines why this is such an important avenue of study. The use of steroids to manage symptoms of brain tumors, such as the buildup of fluid in the brain, may limit the effectiveness of immunotherapy drugs against these tumors, a new study suggests. Immunotherapy drugs, known as immune checkpoint inhibitors, have been effective for some patients with certain types of cancer, including melanoma and lung cancer. But these drugs have generally not been effective against brain tumors, including glioblastoma, the most common type of brain tumor. Some studies have suggested that the use of the steroid dexamethasone to treat symptoms of brain tumors may hinder the effectiveness of immunotherapy drugs for treating glioblastoma. The new study adds to this evidence. Using 2 different mouse models of glioblastoma, the researchers found that mice that received steroids and immunotherapy did not live as long as mice treated with immunotherapy alone, they reported. When the researchers analyzed data from 163 patients with glioblastoma who received immune checkpoint inhibitors through clinical trials or compassionate use basis at Dana-Farber Cancer Institute, they found similar results. The use of dexamethasone was associated with shorter survival. Quote, "We know that steroids have potential side effects, but our findings suggest they also have detrimental effects in terms of diminishing the body's immune response against a tumor," end quote, said Dr. David Reardon. Our results indicate that the use of steroids in patients with glioblastoma who are receiving immunotherapy need to be very judicious. We would recommend that such patients be put on the lowest dose of dexamethasone for the shortest possible period of time. That is exactly what happened with me. I was on a fairly small dose, and I was back off of it 4 days after I had gotten home. Dexamethasone is a highly effective drug for managing symptoms associated with brain tumors, including headaches and weakness, but it is an immune suppressor that also reduces inflammation. Quote, "Dexamethasone is really the only steroid that can effectively decrease inflammatory reactions in the brain to help our patients," end quote. Some patients receive Dex to prevent inflammation in the brain and remain on the medicine indefinitely, but based on new findings, it may be time to reevaluate how dexamethasone is used in brain cancer, the researchers suggests. If the immune system is suppressed as a result of treatment with dexamethasone, then treating a patient with a drug that is designed to facilitate an immune reaction against cancer will not be effective. And that was said by one of the doctors who is an investigator in the NIH neuro-oncology branch who was not involved in this study. In their study, the researchers used 2 different mouse models of glioblastoma, one that tends to respond to immunotherapy and another that tends not to. The second model more accurately represents how glioblastoma behaves in humans, study authors noted. But the researchers wanted to see whether steroids would diminish the response to immunotherapy, even in mice with brain tumors that tend to respond to immunotherapy. By treating some mice with dexamethasone and immunotherapy, and others with immunotherapy alone, they found that the answer was yes. And because radiation therapy is a standard treatment for glioblastoma, the researchers also treated both mouse models with radiation and immunotherapy. Among these mice, the use of dexamethasone appeared to be associated with reduced survival. In addition to the mouse studies, the researchers analyzed data on the 163 patients with glioblastoma who received immunotherapy at Dana-Farber to determine which factors were associated with patient outcomes. Roughly 1/3 of these patients had also received dexamethasone. The investigators analyzed a variety of factors, including steroid use, the size of the tumor when treatment began, whether the patient was newly diagnosed or had recurrent disease, and age. Of these factors, steroid use was most strongly associated with the patient's outcome, the researchers found. Quote, the use of dexamethasone was the strongest negative risk factor for overall survival, said Dr. Reardon. He cautioned that the findings need to be confirmed in a prospective clinical trial. We're almost done reading this study, and I will give some commentary at the end. We know that glioblastomas can evade detection by the immune system through a variety of means. If dexamethasone further impairs the immune system, then by treating patients with the drug, we would be shooting ourselves in the foot. To identify potential biological mechanisms that could explain how dexamethasone impairs the immune response against tumors, the researchers focused on immune cells called T cells, which are critical for immune responses against tumors. We had talked about T cells and their importance in one of our immunotherapy episodes, which I will try to remember to link in the description as well. Treating both mouse models with dexamethasone led to a reduced number of T cells in the animals. If there are fewer of these T cells to mount an immune response against a tumor, then it's going to be harder for the immune system to attack a tumor and provide therapeutic benefit for the patients, said Dr. Reardon. The mouse studies indicate that dexamethasone may impair the ability of T cells to generate immune responses. The steroid may affect both the quantity and quality of T cell responses, Dr. Reardon noted. A related finding, that steroids may affect the development of T cells, was reported in a 2018 study led by Mark Gilbert, MD, chief of the NIH Neuro-Oncology branch. Administering steroids before immunotherapy, quote, may blunt the generation of an anti-tumor response, end quote, these researchers concluded. Future challenges. The new study, Dr. Gilbert said, is critical for the field of neuro-oncology and could bring about much-needed changes in the design of future brain tumor immunotherapy trials, end quote. These studies could help determine the best time during the course of treatment to administer steroids. It may be the case that it is better to wait to administer steroids until after an immune response has developed, but more research is needed. Quote, one of the main messages of our study is that we need new ways to manage symptoms in our patients that do not affect the immune response, said Dr. Reardon. I think it's extremely important that we work to develop new ways that are not dependent on dexamethasone or other steroids in general, especially if we're going to be going the immunotherapy route. Many people that I've spoken to, including myself, did not like being on dexamethasone. It is just one of the worst medicines to be on, and hopefully if you're on it or you know somebody that is on it, some of the side effects are something that we just have to deal with, especially the increased aggression and anger, which can be even more stressful during an already stressful time. Perhaps the increased appetite is not as much of a problem, but then you have to work off extra weight that somebody may have put on. I know some people that have put on 15 pounds because they were on dexamethasone, and then their face gets puffy, like one of the side effects. You get bad acne. Just generally a very negative experience. Nobody really likes to be on something like this. And it makes me wonder why anybody would want to take steroids in the first place if that's what you have to deal with. Not a chance for me. No way. I'm sorry this episode didn't have as much of my own personal input other than the fact that none of us, or the majority of people, don't like being on dexamethasone. But I think it's important to share the fact that a majority of us will have been there at some point, and to also realize that as we're moving into a treatment future where we have immunotherapy as an actual option, we need to be careful with how much we're using these steroids so that the immune response is actually being beneficial to the patient. It seems so obvious, but until we have evidence, we can't really start working towards a future for a different type of treatment that is not steroid based. Something has to be out there, and I'd like to believe that we will find it at some point. Once again, I'm sorry this episode had more of me reading and less personal input, but I definitely will be talking more about my personal feelings in the next month or so. We have our August news recap episode, which I will be working on soon because we're nearing the end of August. I don't know how quickly I will get this episode edited, but I will try and do my best, although it's been very busy with work and other obligations, but I'm trying to get everything done as best I can. I do want to say thank you all so much for taking the time to tune in and listen to the show. We have passed 20,000 downloads on Podbean, and I think that's amazing. It might not sound like a lot to compare it to some of the larger podcasters in the world and on the platforms, but it means a lot to me. I never expected to be able to reach as many people as I have, and it's just amazing. I look forward to doing this. I really, really enjoy just being able to sit here and talk into my mic. I know I've gotten way more comfortable with it as the years have gone by. I cannot imagine going back and listening to some of the earlier episodes where I was super nervous. And I still get nervous, but I'm much more comfortable now, and I feel like my editing has gotten a little bit faster and a little bit better. I don't know, but I really enjoy doing it, and I'm so thankful for all of you. That said, we're going to wrap it up here, but make sure that you like the page on Facebook at facebook.com/braincancerpodcast. Post on there every day, unless I fall asleep really early and then I feel guilty that I didn't post earlier in the day. You can leave a review on the Facebook page as well if you would like. You can send me a message on there, or you can email me at braincancerpodcast@gmail.com. Follow the Twitter that I hardly ever use at twitter.com/braincancerpod. Be sure to follow or subscribe to the show on whatever podcast app you happen to use, whether it's Spotify, Amazon, Apple, Google, whatever. That way, you'll get notified when a new episode goes live. I will be back soon with another episode. I'm going to get to editing this one right now after I get myself another glass of water. Thank you so much. I hope you all have a great day or night, and I will talk to you again soon. Bye.